Hello, and welcome to The Two View, the cutting edge educational show for PAs and nurse practitioners in emergency medicine and urgent care. My name is Martha Roberts, and I'm a practicing emergency NP and professor of nursing in Northern California. And I'm here with my rad EM pal, Mike Sharma, PA. Mike, hello.
I prefer to think of myself as totally tubular, but rad will do as well. Okay, uh, I've had a really great month here. Our middle daughter Mima just had her 16th birthday. Our second
Oh,
16-year-old in the home. Monica delivered her in the middle of my first year of PA school,
oh.
and so it's really you talk to your daughter about, when you were born, this is what was going on in our life. And it was just a really interesting time capsule. My wife and I talking to her yesterday about how our lives have changed in so many interesting ways ever since she was born. So, Mima, happy birthday. I love you.
Oh, I love that. And hopefully, you loved our last episode all about the woes and stress of the holiday season. But, it's still the new year. And in light of the new year, we're bringing you a very special podcast, a podcast of regrets. Regrets. I know that sounds slightly depressing and maybe even somewhat concerning, but don't worry. These aren't regrets about patients who have died, who have had serious complications, or significant terrible outcomes. These are regrets that, I felt in a few cases, or maybe in my personal life related to healthcare, that we wish we could take back these things. And we're going to explain a little bit more about what that means and why we're focusing on it.
Wait, so this isn't where I confess to stealing a bunch of office supplies from my last job?
Have you seen my stapler? Let's dive right into segment one so we can tell you a little more about this. I want to start off with my major regret. And I've spoken about this on the show before a few times, Mike, and it's not about any specific patient, this one. It's about getting a job as a nurse practitioner in a facility where I practiced as a nurse. And the short story here is it's a bad idea.
Oh yeah, I've seen this happen a couple of times. It really takes, I think, a combination of things to go right. And if even one of those things is off, then it really turns out poorly. We used to see this in the military all the time. You move around all the time in the military. Even if you're staying on the same base, you'll jump around to different units as you're promoted through the ranks. And I think that's such an important thing to do. Number one, you're seeing more of how different organizations run things, number one. Number two, you're not necessarily that guy or that gal that did this thing 5 years ago, and it doesn't follow you as aggressively into your new career as a nurse practitioner.
Yeah, I'm going to explain a little bit as to why it's not ideal for a nursing candidate who is starting to become an advanced clinician in their workspace they have been as a nurse. And honestly, I don't even really think it matters if you're going from a tech or a scribe or any of these positions to a different position. Whatever your position was before, it's going to be hard to gain the recognition of the new one. It just is. And there's literature out there to support that, not to mention personal experiences. But I'm going to put it to you simply. Gaining the respect of your colleagues after they've seen you be something else can be very difficult, challenging. And we know in healthcare already that it's challenging. It's supposed to be a team sport, but it can be very troublesome, unsympathetic, and laced with jealousy, confusion. I'm going to expand on a couple of those things a little further. First, I'd like to talk a little bit, again, how healthcare in general, like I said, whether you're a nurse, technician, secretary, scribe, whatever, can be very cruel. And our days are long, arduous, filled with uncertainty. And many patients will get on our last nerve, or colleagues may get on our last nerve, and not making for the most comfortable working space. That's not to say that many days are successful and happy and the world is right. But as we know, ever since COVID and the pandemic, the level of burnout has reached new levels.
And we've really had to work very closely with our colleagues over the past couple of years, sharing our fears, sharing our hopes. And sometimes, as they say, familiarity breeds contempt. It's sometimes it's nice to have that little like slightly separation between the people that work around you. When you get really tight with people and it's not the perfect environment, again, that can lead to bad vibes. in this really intense working environment of the
Yeah.
emergency department or urgent care.
Yeah, so we acknowledge that. I'm gonna tell you about a story that happened in the ED, not currently the hospital I work in, but it was a very cruel experience. And I worked in an environment where I was the only nurse practitioner, and everyone else there was either a physician or a physician associate, and nobody understood the training of a nurse practitioner. This was a long time ago, but it's not like we were brand new or anything. The career that is, or specialty, and I felt like, you know. I couldn't really fit in. I thought I was competent. I did good training. The physicians felt like the physician associates had more of a medical approach rather than the nursing approach, whereas the physician associates felt like their education was better than the nurse practitioner because they were focused on the medical care. And I often argued with them about the fact that nurses witness and help with intubations, central lines, other life saving procedures on a daily basis. I mean, we saw lots of them. And that gives us a lot of bedside experience, and it allows us to really tailor those expertise when we become advanced clinicians. We're very good proceduralists, as sometimes physician associates don't necessarily have that robust nursing or medical experience before they get their advanced degree. And I'll let Mike talk about that training in a little bit. But nurses are required to work a certain amount of nursing hours before they become a nurse practitioner. And that really gives us a good perspective on patient care.
Yeah, that actually is kind of the rap on physician associates is that, hey, you could have been some random thing before you applied to be a PA. But actually, this is kind of a misunderstanding of where current PA enrollments are going. The trend seems to be that PAs PA candidates that are applying to become PAs more and more often are needing real patient care hours, not healthcare hours, because I mean, you can be working in healthcare and be pipetting solutions in the back of a lab somewhere, but often what's being required for PAs nowadays is real, hundreds of hours of patient care experience. And so that I think is a good thing. And when it comes to NP education, for the vast majority of NP schools, bedside care was required to be admitted. And I think this is a good thing that PA education, I think, has co-opted from the NP profession.
Yes, I absolutely have mad respect for all of you. I don't want anyone to sit back there and be like, hey, like, what is your problem? Why are you saying that about PAs? I'm not saying anything bad about PAs. I'm just telling you about a situation that I was in at the time. And I had to perform at that time. The rule was 5 years of bedside nursing experience before you could even apply to an NP program. Like, legit bedside healthcare experience. And I understand that both of our specialties are evolving, but as I was saying, in this particular situation, I was an outcast. I got the worst shifts. I was never invited out for drinks after work. I never got the shoulder reductions or the huge RVU cases, and people would often question my abilities. It was like, and regardless of PA, it didn't matter. Like everyone, the nurses, everyone. It was like that scenario where you felt like everybody was laughing at you and you were kind of left out of the joke. And on top of that, the RN staff bullied me to no end. Other things like I would ask for medications or ask for a chaperone for a pelvic, and they'd say, just do it yourself. You're the nurse and the NP. I mean, it was rough. And I've talked about this on prior shows. So needless to say, I got out of that experience. And when I got a new gig, wow, what a huge difference.
That is, we've talked about this before, and it still really bothers me that you had that experience. I think it really speaks to maybe you listening are a new grad. And what's crazy about being a new grad is that even though you may roll into the job with years less experience than the nurses, the techs that you are working with in the ER or the urgent care, you are still an executive in that place. You are a decision maker. You are a trigger puller. And so you can try to fit in certain ways to the culture that you find yourself in. But I think you have to be aware of when fitting in is the wrong thing. I think you have to be aware that sometimes purely through the way you act, you don't have to tell anybody, hey, you shouldn't talk that way or you shouldn't do this. If you just act the way that you wish everybody around you would act, I think you would be shocked about how much you just being a great PA or a great NP can change the culture in a
Yeah.
place that maybe is not having the best culture.
Yeah. Well, that's what I ended up doing, and it worked out for a little while until it didn't, and I moved on. But it did make me overcompensate quite a bit. I mean, I got heavily involved in teaching. I went back and got two more master's degrees. Like I took it a step too far. I do regret, actually, you're talking about your kid's birthday. I mean, I was pregnant, working two ED jobs, and getting an additional master's degree at the time, and I got married, and so it was too much. I do regret that. I wish I had taken it a little bit slower.
So there is an article you shared with me about this kind of topic, relatively speaking. It's by Mary Shea, who's an NP. It's in the Journal of AANP, and it's called Determined Persistence. Oh, I love this topic. My wife and I have this saying about basically, quiet persistence, about how if I just model the right behavior for my kids, eventually they'll quit leaving mounds of clothes on the floor. They'll eventually put the forks into the dishwasher the right way. Okay, so yeah, this
Whoa.
quiet persistence is so important in our family life, but this is how it can matter in our clinical lives as well. And the subtitle here is Achieving and Sustaining Job Satisfaction Among Nurse Practitioners. The participants described holistic care as the foundation of their work as NPs and their relationship with patients as determining factors of job satisfaction. How interesting. When NPs felt, though, that patient care was compromised, that is when job satisfaction took a dip, when patient care was compromised for whatever reason. When NPs are providing that holistic care they're trained to do in an environment that respected their individual values, that was when NPs felt the most satisfied with their jobs in this study.
Well, I'm really going to get to the point of why I chose this article and the next. And that is because, from what I take from these types of papers, is that sort of what you already said, in a way, that if you center yourself around patient care truly, you will be much happier. And if you don't let certain colleagues piss you off or control your mood. There are a lot of things that can influence your work balance, and it's hard to argue when all of you are trying to be focused on the patient and keep coming back to the patient. So, for example, when I said to a nurse, I need help with vital signs, I often followed that up with like kind of this backhanded compliment with, I was worried about that patient. I was curious if you, the RN, could take another look at them and reassess them too before we discharge. Just toss in some vital signs in the chart so we're all good. And then it's pretty hard to say, no, go do it yourself, right? I mean, I have to kind of think that those types of things work in those areas of turmoil. And then there was another article by Kelly and Matthews in 2001, so a long time ago here, but it still rings true. And this was in the Journal of Nursing Education, and it was entitled The Transition to First Position as Nurse Practitioner. Some really powerful stuff here. The nurse who graduates from a nurse practitioner program leaves this comfort zone of nursing, as we know, and they're put in this new position where they're feeling maybe some insecurity and stress that's very common. But the purpose of the research that they did here was to obtain a better understanding of the transitional phase to the first position as NP after graduation and the perceptions of preparation, gains, losses, barriers, facilitators, and strategies for adjustment were explored, and a qualitative approach using focus groups was developed in 21 recent NP new grads from a large university, very interesting results.
Yeah, I wanted to, before I go into talking about this study more, I wanted to highlight something you said where you were working with this RN and you asked them for help. And this is actually, I'm kind of a big believer in some of the techniques that are discussed in this book by a guy named Chris Voss. Chris Voss, I might have mentioned him on the podcast before, previously was the FBI's expert in international hostage negotiations. And now, of course, he retired and he's doing his own thing as a consultant, as a speaker. And so he has a book out there called Never Split the Difference. And, I think you'll find, as maybe you listening, eventually you will become a more senior clinician and the medicine in a way gets easier. It's the peopling that gets hard is dealing with the people around you, whether it's staff, whether it's patients, that becomes more stressful than the patient care. And so something he mentions, and I'm going to land this plane, I promise. Something he mentions is, you know, some people really want control in negotiation, control in a relationship. And an interesting way to involve people in finding a solution during a negotiation is asking them for help. And so I think it's really insightful what you did there is you asked this RN who maybe you had a rough relationship with, you asked for help. You recognized, at least in words, their expertise, their knowledge, and you said, I need your help. And you kind of showed weakness and vulnerability. By the way, I'll do that with patients sometimes. When I'm really struggling, I'll ask them like, hey, help me out. Like, you know, how can I help you here with this problem you've got going on? And often that will take a patient or maybe a staff member who is kind of in their head a little bit too much and they're kind of feeling big feelings, as my friend Kyle likes to say, and shift from feeling feelings to, oh yeah, how can I help? What is the how can I get to the end of our discussion here? So I love that, asking for help. Anyways, it was such an impactful thing that you mentioned. I wanted to really highlight it. Getting back to this research, talking about this transitional phase from RN to first position as NP after graduation. This study used techniques like peer debriefing and participant verification techniques for the study, and they went over some themes about loss of personal control of time and privacy. Oof, that's a hard one. Changes and losses in relationships, because you now have a different relationship when you are an NP and not part of the RN team. Feelings of isolation and uncertainty in establishing the NP role. Oh man. And a special bonding with clients. Although the participants perceived that they were adequately prepared for their new role as NPs, they also described to the authors this feeling of guilt and uncertainty from having a hard time just not knowing some of this medical information that they thought they should know as new NPs.
Yeah, so the reason why I chose this one as well to look at is because they looked at this special bonding with the clients. Again, they concluded that the functional role of this NP really, you know, it was different than the physician and certainly of the PA, and as well different from what the nurses were doing. But there was this, you know, imposter syndrome and a lot of variables to try to get through. But everyone experiences that in a new job. But finding a comfort zone, whether you're a new grad, a new hire, with experience, whatever, is allowing this feeling of uncertainty to exist and just move forward and make a special bond with your clients. Again, that theme rings true, that when you make the patient the center of your focus, I think it's going to be really hard to argue, fight, feel weak, all these things, because the patient is empowering you. And so I remember, I mean, I worked with this horrible woman, just absolutely atrocious. I was suturing somebody's hand, and she was a PA, and she came over and she said, your glove touched the sheet. And I mean, like, I don't know if it did or not, but she ripped the tools out of my hand, threw them in the basket, said, you're going to have to get a new kit. I didn't ask for her help. I wasn't on orientation. Like, it wasn't my first day. And then later that day, she yelled at me and said that my sign-outs weren't complete. And I'm like, I have to leave at some point. Like, I don't have the results of the CT. I'm sorry. And so, you know, I just went back. You know what I did? I went back, and I'll never forget it. I went back to all the patients I was taking care of. I said, goodbye. You know, this wonderful PA is going to be taking care of you. Their name is blah, blah, blah. And then I just grit my teeth and went home. And then I found a new job. And honestly, just putting the patient first, you know, namaste. That's it for that.
There you go.
So moving forward with more regrets, because you're going to have more, Mike. We're going to have more. For segment 2 for our dry scan, I want to talk about 2 patient case studies and some regrets that we've had in regard to patient care. And Mike, I'm going to let you start with the first case, and then I'll chime in with mine.
Yeah, I have kind of a twofer here. I think my first, I have broad regrets, and I have one particular encounter that has stuck with me now for several years, and it really kind of, when I think about it, it really brings me back to that time and place where I was. So my broad regret that I have when I interact with patients is, I'm not going to lie. Sometimes I am not the best at de-escalating situations. Sometimes, you know what? Sometimes I have an idea of the end state of an encounter with a patient, and sometimes I will intentionally, not in a mean way, escalate things in a way to achieve that end state a little bit faster.
Yikes. Yikes.
And I'm not going to call them names or whatever else here, but sometimes I'll move things along faster. I will. Anyway, short story is, I feel like every time I intentionally take someone who is already being activated and I further escalate back at them, I think, generally speaking, I regret when I do that. I think my best, because not only is that destabilizing for my relationship with the patient, stepping back a little bit, I realize that it's destabilizing for everybody around me. No one likes to be in that setting where providers and patients are kind of going at it back and forth. If you can kind of do a little, Jedi hand wave, these aren't the droids you're looking for, that kind of a thing, then that I think is a much more important skill. It's not as flashy as you jacking your jaw at a patient who's being mean, but you being able to get in there and use a few words, take the temperature out of a conversation. I think on my best days, that is what I do with patients who are activated. And I regret those times broadly when I don't do that. So that's one set of regrets there. Martha, I know that you've mentioned, and I'm kind of taking you kind of this is a little bit. I didn't prepare you for this, but like you've mentioned previously, you often like to interact with those patients who are being regarded as difficult by other providers around you. So, like, how do you do this? How do you take it? Assuming you don't escalate with these patients, you find some sort of Martha way to de-escalate and to handle the situation. So, do you have any particular tips or tricks when someone is activated, agitated, beyond darting them with some droperidol? How do you get them to calm down a bit and be more collaborative in their care?
Well, I appreciate you recognizing that. I also like to be friends with some of the most hated people at work that turn out to be really cool. They might be weird, but I look, I know how it feels to be the out person, the person out on the sidelines. I think when a patient is difficult, there's probably a lot of bias against them for whatever reason from the get-go. And I can be difficult. I'm a very difficult person to live with, says my husband. And I get it because we all get stressed and agitated and it doesn't come out well. Oftentimes we learn this new phrase in our household that we say when someone is being agitated or irritated. What was your intention with that comment? Would you repeat that comment? What were you trying to do when you said that to me? And so a lot of times if a patient is being like ridiculous, whatever, violent, yelling, doing all these things, I just sit down and I go, hey, can I take a listen to your lungs real quick? And patients will always let you examine them. Maybe 1% of the time they won't, but nobody wants to seem to touch them. So you just give them a touch, even if they're like backing off from you. Like even my psychotic patients, like they're talking to whoever they're talking to in their brain, but they still let me listen to their lungs. They still let me listen to their heart. They let me examine them. And I just kind of sit there and kind of just let them talk, and lots of refocusing, lots of redirection. That's not to say I don't get angry or irritated. We talked about this in our 40 things in 40 years, 40 years until we get there, 40 things that we learned on our 40th episode. And one really was just knowing when to take a time out. So like I step away and I'm refreshed. I step away and I'm refreshed. So those are my suggestions. Sit down, examine the patient, find out what seriously they're mad about. Is it really the fact that you didn't get them water, or is it that like their ankle's broken? Like they just want attention for their ankle, and why are you ignoring them? And then just take a break. Take a break and come back. Those things always help.
Yeah, that's funny. I distinctly recall a patient I took care of one time where, for whatever reason, we were just getting crosswise with each other. And so, I just stopped and I was like, look, I feel like things are getting a little bit tense between us. That's not what I want. I don't think it's what you want. So I'm just take a break. And I'm going to come back and we're going to kind of wrap up with the problem you're bringing us here today with your medical concerns. And it's really funny how just kind of taking a break and taking a breath, physically removing yourself from a situation, and then returning, sometimes that can really hit the reset button on an interaction. So that's really cool that you kind of found that as well.
Yeah, you got to do it.
So my particular regret that I had one time was it was kind of like a cascading kind of a thing, right? So I'm working in this urgent care that I didn't feel very supported in, frankly. I didn't think that and this is not what I work at currently or have in years, frankly. I didn't feel like the practice owner was very responsive or respectful with some of the decisions I was making. At the same time, they also weren't available when I tried to consult them on patient care. So it's kind of like I was kind of darned if I did, darned if I didn't kind of a thing. Mm-hmm. And so already I'm feeling kind of chippy working in that place. And then the staff comes in and they say, these people are always here, right? So this family is coming in wanting a refill for the daughter's albuterol. And it's, if you just take a second to think about that, right? It's like, wait, you have a patient that is a return customer to your urgent care. These people should be the VIPs. They shouldn't be like how dare this person come and pay for care at your urgent care clinic and keep the lights on? It's like so many things were going on. I was feeling chippy. The staff is chippy. We're all kind of just like, feeling big feelings. And so I get cued by the staff member about this problem patient who's going to pay us money for a simple albuterol refill. It's like this is like a pop fly to center field. I should be able to like catch this and we retire the side and it should be great. But because of all these things, I kind of go in all grumpy and I see, the mom's there with multiple daughters are there. And, the mom is like, yeah, our daughter has asthma and she's having a flare of her asthma right now, and we ran out of our inhaler, and we just need to get a refill of the inhaler. And so me being Mr. Chippy that day, I'm like, well, do you guys have a primary care doctor? Your daughter has this chronic lung condition, and she could get really sick if it's not managed well. So like, I don't get it. Like, don't you have a family doctor that you can go to and keep her in the albuterol so she's not suffering? Really kind of like, really kind of putting it to the mom. And again, this is me trying to kind of escalate to an end state potentially of trying to kind of like zip it to like, hey mom, like you really should get a pediatrician for your daughter here who can do this. Again, not recognizing that this is the easiest visit I'll have all day.
Yeah, what's wrong with you?
I don't know. Like multiple therapists have tried to figure this out. So I asked that question and she goes, oh yeah, well, we've just been so busy and all. What with my husband being in the hospital?
Oh.
And so number one, that's where I'm the jerk right there. It's like, hey, Mike, maybe there are other problems in this world that are more important than you feeling sad for yourself about having a six-figure job working in an urgent care, doing albuterol refills. Like maybe there are bigger struggles in this life beyond what you're feeling on this day. That's number one. Number two, she says that, and just something kind of like doink, like clicks in my head. And I look at her last name and I look around the room and I was like, wait a minute. Your husband, is he so and so, like Mr. Bob Smith. Of course, I'm not. It wasn't Bob Smith. I'm just gonna make up a name. Um, Bob Smith. I took care of Bob Smith a week ago. He was here and he was having problems breathing, and I sent him to the ER. Is that your husband? And she says, yeah. You thought he had a pulmonary embolism, and you told him to go to the hospital, and he's now hospitalized and he's getting treatment for a PE, and he says that you saved his life.
Oh, bam.
And and this was a patient, by the way. So they were a bounce back to me. They were diagnosed by somebody else with pneumonia. Because guess what happens, right? You have somebody who is tachycardic and hypoxic, and so you're worried about them, and you shoot a chest X-ray, and the radiologist says, looks like pneumonia. Now, if you are not clinically correlating, as we all should be doing, you might read that and go, radiologist diagnosed him with pneumonia. Good to go, you know? And so prescriber gave that person some fluoroquinolones or whatever, sent him on the way. And so he bounced back to me and he says, I'm not doing better with this antibiotic. And I feel like I'm getting more short of breath. I'm having more chest pain. And so I take a step back and I'm like, okay, you're still tachycardic. You're hypoxic. You're not febrile. Hey, random question. Do you happen to have a leg that is painful and swollen, by the way? And he goes, yeah, as a matter of fact, my right leg is killing me just like the last time before I had my last PE. And I was just like, oh my gosh, you need to go to the hospital right now. Happy to call an ambulance for you, this, that, the other thing. And so, as is often the case in urgent care and emergency medicine, you take care of these patients and they transit in and out of your life, and you have no idea what happens to them. And I was just given this gift by this mom and her kids, who I was just so PO'd about having to, of all things, refill. I wasn't being asked for Norco or Ativan. I was being asked for albuterol, a life-saving medication. I should be thrilled to provide this life-saving medication to this family. And they were the ones that gave me this amazing gift of just seeing the scope of what we do, and some of these things that we have no idea about, these patients who leave our care, what they go on to do. And she gave me this, the universe, and she gave me this tremendous gift. And not to get so deep into this, but just since we're talking about regrets, what struck me the most is I look around and I see this mom is taking care of, has three daughters with her, right? And at the time, I had 3 daughters. And I thought about, like, what if this guy had gone home and died? What would this woman's life be like? What would the lives of these 3 daughters be like growing up without their father? And because I'm a selfish a-hole, I go back to my own life and I go, what if I died and my daughters grew up without me? And I still have this flood of emotions that goes through me when I think about this family. And I hope they are well out there, and I wish them the best, obviously. But yeah, that was my regret, is just treating this lady so poorly. And she could have just, said, yeah, well, I need to refill, and that's it. And not shared with me that, like, all these things. And so I am, as much as I am eternally regretful, I am also eternally grateful about that encounter.
Did you give the albuterol, Mike?
No, I told him to go to the PCP. No, I'm kidding. Of course, I refilled the albuterol. Yes, definitely speaking.
Jeez. Oh my gosh. That's a lot. I mean, you know me, I always like to throw in a little bit of humor, and with patient care. Sometimes it's a little cheesy, but you try to get somebody to laugh, and hopefully you can change the milieu of sadness that might be happening.
Oh, I'm totally, by the way, we're talking about techniques here, right? Humor is such an individual thing.
It is.
But if you can get a patient to laugh or smile
Yeah.
when you first meet them, you've got them.
Yeah.
And you have to use that power for good and not evil, of course, right? But it's like if you can, establish, and that's part of establishing rapport. We talk about
Mm-hmm.
a debt, acknowledge, introduce, blah, blah. There's no room in there for crack a joke or notice something the person is wearing from a fandom they love and like make that connection with the client as you described from your previous study. And if you can get them to smile or laugh or just break out of
Mm-hmm.
this, they're sad about being in the ER for 12 hours, understandably, who isn't? But if
Mm-hmm.
you can get them to crack a smile, you own them for the rest of the encounter in the best of ways, and you can. It really makes it easier. All the medical care is easier because you peopled well.
Honestly, you have regrets about that case, but, my new phrase that I've been using is, did you go forth in good spirits? And I've been using it a lot lately. It's like someone told me they got a divorce, and I said, oh, I'm sorry to hear that, but hopefully you're moving forward with some good spirit. Honestly, it's been working because I don't know why, but I really like the phrase. So you could try that too.
Okay.
Is it time for my case?
Yeah, let's do it.
Similar stuff, but maybe a different approach. So I'm going to start by talking about a case of one of my patients who was homeless, daily utilizer of the ED, young, thin, malnourished guy, about 35 years old. He comes to the department every day, lice infestation, needs social work, ankle pain for years, all kinds of stuff. And the guy really didn't have any significant medical problems. Like he never had broke his ankle. He ended up never really having lice, but that was his complaint, an exposure or something like that. Whatever. His labs were always normal. His EKG was pristine, like surprisingly. He did do drugs occasionally, sometimes was intoxicated. And we all have patients like this. And sometimes we don't really know how to help them. But the first sign of regret here is thinking that you can't do anything to help someone. And that took me a long time to learn.
That No, okay, so clarify that here. So you're saying that thinking you can't do anything to help somebody, that makes life harder on you, or what do you mean by that?
So a lot of times these daily utilizers will come in and the nurse goes, what are you going to do for them today? Or one of the physicians will be like, I don't know how to fix this. Like, I can't do anything. Like, what am I going to do for this guy? I can't fix his homelessness. I can't fix his drug stuff. Like, I can try to do some of these things, but like that regret immediately is thinking, gosh, I really feel like I can't do anything. You can always do something. You can always do something.
Okay, I see what you mean now. Yeah, I think that has to do a lot of identifying what I can control. Like we're really getting meta here in terms of like job satisfaction, but it's like there are certain things in any workplace that you can control, and there are certain things that are well outside of that control. And so it's so important as you grow up in a workplace to identify that line
Yeah.
of what I can control and what I can't control. And the things you can't control, I think you just have to kind of like offer that one up and say,
Yeah.
this is not my problem to fix, but what can I fix? What can I do? And that idea of I have agency, I have something I can control, more than it being good for the patients, I think it's so good for us as individuals to feel that I am empowered to do something here.
Yeah.
Maybe it's something as simple as bringing a warm blanket or a chicken salad sandwich, but I can do something.
Well, that's where the story is going next. So the first time I saw this patient, many of the nurses said like, oh, good luck with that. You get to know patient X. We're rooting for you. Like they would say, like they'd go on to say like, take a look at his charts before you go in there. For this particular patient, I decided not to look at his chart. And I've talked about this before. I didn't want to see his history. I didn't want to have any reason to do anything one particular way. I wanted to start new. And in the past, I regret looking at some patients' charts who came in every single day because I feel it created a really unfair bias. So for this particular patient, I decided clean slate. So I started talking to the patient about why he was there. Particular scenario was that, he had pain. He just said, I had pain. And he goes, well, why didn't you look at my chart? Like strangely. And because I guess everybody kind of treats him a certain way. And I told him that he was a new, kind of patient to me. I wanted to start fresh. He looked at me even more confused, and he said he just wanted a medication refill. And I said, "What's the medication?" He said it was Motrin. But I decided to take a full, thorough history and perform a physical on the patient. It definitely took a little bit extra time, but I don't regret that. And I had him remove all his clothes. I examined him and his skin. I did a solid auscultation of his heart and lungs. No labs today, no imaging. And sure, I'll refill the Motrin for your chronic pain in your ankle. And after I finished doing my eval, I sat down and asked him about his goals in healthcare. Sometimes I have that conversation. What are your goals? What do you want? What do you want to happen next? And again, he seemed really confused by this question. So I went a little bit deeper into detail with him, and I told him, feel free to just tell me anything you want about what, is maybe limiting you, like all these kinds of things. And he told me that his story about being homeless. And one of the questions I often ask patients is, where is their family? Where are they from? Do they have any friends? And I know this sounds kind of ridiculous, and we're not really there for chit chat, but what I do regret was not asking other patients this, because when you do this, it opens up the door and it allows you to potentially make a significant change. And I highly suggest you try to do this the next time you talk to a patient if they seem hopeless, hapless, or helpless. And what I found out from this guy is his family was back in Florida, and he had a bachelor's degree, oddly in finance, but he lost his job several years ago, and he got in an argument with his parents about his drug use, which he was using to cope with the loss of his job, and they kicked him out because he was living with them. And ever since then, he's had no one to support him or help him, and he's just been on his own.
Man, I can think just today, in the past 8 hours, how much I am grateful to my wife, to my family for supporting me, and to think of somebody who feels that alone. That's really hard. It's a hard position for him to be in, and I wonder when the last time was that anybody asked him these questions.
Imagine when you go to your primary care doctor, Mike, because I know you do, and you tell your doctor something and they acknowledge it, and you feel able to just say, "Man, I'm feeling really depressed," or, "Will you give me the name of that therapist? I'm going through a divorce," or, things that you may not want to admit to friends that might make you seem weak or vulnerable. And so this guy, he's looking at me strangely because I'm acting like I care. That's the saddest part. That's what really bothered me. But to go on, it's really easy to fix things like lacerations, do a chest pain workup. You find nothing, do a CT scan, rule out an appendicitis. All these things we do a really good job at. But what we don't do a good job at, I think sometimes, is about asking patients about their next step or their plan. And at the end of our conversation, he agreed to give his parents a call back in Florida. He said there's no way they're going to answer, though. And they weren't going to talk to him. So I said, "Hey, you want me to call him for you?" Just like that. "You want me to call him for you?" And he lit up, and he was like, "Yeah, would you call my parents?" Can you imagine, you're in your late 30s or 40s and you're like, "Can you call my parents for me?" Nobody wants to really say that. And so I called him up and I said, "I have your son here and he'd really like to speak to you." And I left the phone with him and left the room.
I was telling you that my mom was just in the hospital for RSV, and thankfully she's out now. Everybody, she is beating that nasty virus, and she's back home again, and back to testing with full capitalization and punctuations as she does on her text messages. And I was really grateful because she has some interesting wrinkles with her health history. So grateful about the time that the physician took to talk to me, because it's really easy to think you know everything you need to know. All right, old person, they got RSV, whatever, But there are some really unique things about my mom's health that it's really important that is not stuff that anyone thinks about on a regular basis. And so every time that the physician would call me and update me, I just really made sure to thank them for their time. And maybe you aren't thanked every time you talk to somebody's family, you talk to someone's brother or sister or spouse or parent, but just know that when you do that, the family is so thankful for that extra time that you spent with them.
Yeah, so really to finish this case, we'll talk about calling family a little bit more when we look at this study in a second here that I pulled up. But we took care of this guy's problem, right? And I discharged him and talked to his parents, all the stuff. The funny thing was that he didn't come back for like a week. The nurses even mentioned, I haven't seen so and so here today. And then we were all like, oh no,
You
like
killed them.
what happened? But the following weekend, I was back and I noticed he was outside, clean clothes. He was sober and he had a phone. He never had a phone. And I sat down and I said hi to him. And he even said since that visit with me, his parents have rekindled the relationship with him. And actually, they sent him some money for this phone, which he said, I'm not going to abuse it. You know, they did me a favor. And they also gave him a little bit of money, which I know is not necessarily like what everyone would do, but it allowed him to stay in a hotel, get clean clothes, and focus on his next healthcare steps, his goals, the things we actually talked about this guy was doing. Weird, right? So he met with social work. And of course, I was kind of shocked to hear all this information. It was quite rare that something like this would happen. And he said he had an appointment that day. That's why he was there for the outpatient clinic where I had set up an appointment, a referral, for him to get started on some treatment for his addiction. So not all stories end like this. And I don't know what happened to the patient after that. The funny thing is that I never, ever saw him again. And we certainly would like to imagine that good things happened for him, that he went forward in good spirits and maybe even moved back to Florida with his family. But I haven't had that conversation with him. And I think if I hadn't had that conversation with him, I don't know if I would have found him that day well dressed, preparing for a healthcare appointment and getting his life back on track. I regret nothing from being kind and taking that extra step. In fact, I like talking to his parents. They seemed really nice. What I do regret is not doing that for other patients in the past.
That's so hard. I don't know. I'll just, number one, thank you for sharing that with me, and it makes me think of my interactions with our, as I describe in their charts, extraordinarily heavy ED utilizers. But it makes me think about, what I could do. Like, do I have control over maybe not fixing every problem they have, but do I have control over taking 5 minutes that day with one person and asking the next question, asking them what their goals are, maybe uncovering some information that isn't obviously apparent even despite this person coming to the ER, more times than me, and I work there. Sometimes those extra 5 minutes, you may not, as you're listening to this podcast, you may not recall when was the last time you spent 5 extra minutes with a patient. But you do it often enough and it'll make a difference for them.
Yeah.
Well, speaking of calling family, there is a cool paper in the Journal of General Internal Medicine. Much better than the Journal of Specific Internal Medicine. But anyways, it's called Making the Call, Engaging Family as a Critical Intervention from November 2022. That is, again, the Journal of General Internal Medicine. We are going to have links to this article on our website. That is, of course, 2view.fireside.fm. It's the number 2view.fireside.fm. And this article details a situation in which the author was with a patient who didn't want to call their family at first because, you hear this from patients from time to time, right? I don't want to burden anybody. I don't want to be a burden. This patient ended up passing away 2 days after the encounter, before her children could arrive at bedside. And you play this game long enough, you are going to run into the situation where somebody has a serious illness and their time is not measured in years or months, but in weeks or days. And they, for whatever reason, kind of withdraw. They withdraw from medical care. They withdraw from family. And, maybe this person has a terminal illness. But when we're talking about the end of days here for this patient, the delays, that withdrawal can cost everybody. It can cost the patient, it can cost the family dearly. It can rob the family of that opportunity to say goodbye, or to obtain closure to where this family now is maybe not moving forward in good spirits, as the phrase you utilized earlier. So the authors kind of zoomed back out after detailing the situation, and they suggested some solutions to avoid the theme of our episode, regret. They suggested a structured approach to engaging families of these seriously ill patients. Of course, we assume the patient is still at least with it enough to have decision-making capacity. So first, you ask the patient who should be involved in shared decision-making. And this is kind of a weird question to ask a patient because they're thinking a lot of big things at that point. When you've informed them you've had serious illness. And so you don't want to say, is there anybody that we should involve in your shared decision-making? Because that's more of a yes-no. You say, who should be involved in your decision-making? Okay? And so you're already kind of normalizing that this is a thing they should ask somebody else. If the patient declines to involve anybody, rather than you just say, okay, you use that no as a jumping off point. And again, not to be like a Chris Voss advertisement, but often finding no is a really important part of a relationship you have with somebody. Because, people can say yes, 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 and kind of just like, say whatever they want to get you out of the room. But if they are willing to do what is somewhat socially unacceptable, to say, no, I'm not doing that. That's an interesting point to say, oh, wow. So, we were going along just fine, but this was a no for you. That's so interesting. So like, that's when you can ask those questions you asked that gentleman. Like, who are your friends? Who are people that you're close to? How often do you guys hang out or talk? And how do you do that? And, you kind of like get them thinking about, hopefully somebody they have in their circle. And then you ask them like, so like, is there something preventing you? Like, what is preventing you about sharing this really important news from this person that you're so close to? What is your concern here? And sometimes you'll get blown away by the information, by what is concerning these patients. And that gives you, again, that jumping off point of, oh, now that you know the concern, you can kind of address it. And by the way, I use this all the time for patients who are being admitted but are concerned about being admitted. Like, they may say like, well, I don't know. And I'll ask them, instead of saying, well, figure it out and I'll come back in a few minutes, you can say yes or no. I'll go like, oh, like, I mean, obviously you're concerned about what's going on here, but you're also worried about staying with us and getting better. Like, what are you worried about? Can I ask? And they might tell you like, well, the one I got most recently, just a few days ago, was, well, I don't have any clean clothes. And I was like, oh, well, I mean, well, we have hospital gowns. Consider when you're ready. I know it's kind of a hospital gowns. Who wants to wear a hospital gown? But consider you can change into a hospital gown, save your clean clothes, don't sleep in them or whatever. And then when you're ready to go home in a few days, you got this fresh set of clothes you can change back into, and then you just kind of toss the hospital gown into the linen basket. And like, I was just so surprised at how this just seemed like a revelation for this patient. They were like, oh yeah, I guess I could do that. So sometimes you'll be surprised about why it's a no. And you'll also be surprised as far as, what you can do to affect that no.
Yeah, so just some of those questions that you asked, who's the inner circle? How do they keep in contact with you? Who can we share this with? What can we share with them? The answers to these questions help the clinician assess how and when it's appropriate to contact family in, these particular situations. And then you can lay this groundwork down when they have serious issues like this and transition for care and planning and all that stuff. So, lastly, despite ongoing attempts, sometimes to do this with family, they still may say no. Don't just say, fine, forget it. Offer them something else. Be like, do you want a chaplain? Do you want a social worker? Would you like a nurse of this particular specialty? If it's a palliative care nurse or something else or an ostomy nurse, whatever. These clinicians can give really unique skill sets, and help fill in some of these issues, or fill in some solutions to the issues that the patient is having. And in challenging cases, the authors of this paper also recommended, just consulting palliative care. It's not just for the support of people who are dying, it's people who are terminally ill or have a serious illness.
This paper has a lot of interesting figures, references, points to consider. So again, 2view.fireside.fm. That's the number 2view.fireside.fm, and you can check out that link and to read everything we're talking about on today's episode.
All right, so we're going to end this episode, segment 3, here with something very positive. And it will be still about regrets, but it's going to be positive, Mike. And I'm taking a position at a new place. I need a 5th job, but I really got into looking at all the different things that they had to offer for per diem employees. And that's something that I regret not doing before, taking full advantage of my benefits from my company and what they had to offer. That's always something you should look into. Free subscriptions, CME payments, pet insurance, all the things that your hospital offers, a break room that you never knew existed until 5 years after you started working there, the private bathroom, whatever. Mike, what are some cool things that your job offers you?
I'm still hung up on pet insurance. Are we like, in case the pet gets in an accident driving around town? What are we talking about here exactly?
No, I mean, it's pet insurance. So like if your dog has like an $800 surgery, you pay like a $50 deductible.
Huh. Okay, something to consider. All right. Well, yeah. So cool things my job offers me. I live in Dallas. The state fair is here every year, and so we can have discounted tickets to the state fair. That's pretty cool. Oh, what's another one? It's new year, new me, right? And so a lot of and this out there, if you have medical insurance, really dig into as boring as this sounds, look at the website for your medical insurance, because you will be surprised at how you can get discounts on things like cool bone conduction headphones, cheap gym memberships. I mean, there's a lot of cool stuff that if you're wanting an elite, whether it's just something as simple as buying new electronics for yourself or getting a new gym membership, trying out that new hot bar yoga place or whatever, you can do these things for relatively inexpensively and try something new in 2025.
So additionally, Mike, I think taking advantage of changing practice policies. So this is taking advantage of the staff that you work with. So take a look at any changing practice policy or medical review case, or by actually paying attention and the accompanying literature of these presentations that your colleagues are giving you. So let me explain. We have a physician at UCSF, Dr. Christopher Peabody, who reviews cases and sends out this beautiful single PowerPoint slide about a case. It's either good and sometimes it might be bad, but he clearly puts a lot of work into them. And I know much of the staff doesn't read them because they get 100 emails. But I opened one up, recently, and I was delighted to see that it was a case I was involved in. And I reviewed the MR. I learned a lot about what could have gone better, some best practices and some practice changes, and what our department does and offers. It was worth the effort, and I'm building upon the education of complex medical patients. So Mike, have you had a case go to the medical review board or something interesting lately that you wanted to share?
No, my life is completely lacking in interest. No, actually, yeah. Let's see. I'm trying to think of anything in particular interesting that I wanted to share.
And if you don't, it's okay. I just think the fact that you even start thinking about cases that maybe went to MME or something, for review, take a look at that and let that kind of be something you don't regret later, like, oh man, I missed the in service on how to do, how to use this new suture kit or whatever. Like, dang, now my boss has to like write me an email that makes me feel bad. Speaking of which, I like to review anything that comes from my boss directly, meaning any email, any PowerPoint, any information that they send. It's really important because think about this. If it's important to them, it's definitely important to me. I don't care if it's patient census, left without being seen stats, admission rates. I don't care. Even the new social medicine consult service hire. I look at that. I really try to make an effort to pay attention to those key things from their communication. You will regret eating in the sign out room when your boss strictly sent out a memo that said, please eat in another break room when we do sign out to avoid distraction. So take your bag of chips elsewhere.
That's, I think, a really important thing for new clinicians and really anyone just entering the job force. In the military, the phrase used to be, know who your rater is. And what that means is, in the military, you get reviewed, you get rated by your boss periodically. But what's hard is when you're the new person, everybody outranks you. And so when you go to a new hospital, everybody's been there longer than you. And you may have lots of people that are trying to give you advice or tell you do this or do that or pay attention to this. You got to know who is your collaborating physician, who is your ED chief, what are their priorities. And I totally agree. If my boss cares, I got to care because, he or she probably has, is seeing things at a different level. Even if they don't share all the details of why a certain thing is important, they have a lot of things to do. If they're taking the time to explain something, I better listen.
Right. Now, you can't do all these things, Mike, and stay on top of the workplace environment in one day. So I pick a few days a month just to go in and work on my email, get there an hour early, and then I do some callbacks. I see how people are doing. It helps me tremendously, and I regret nothing about doing that because I get to be able to see what happens to people. And lastly, a shout out to Mindful EM, a column in a magazine I worked for almost a decade, EM News. This is a piece written by Doctors Hazen and Haber in May of 2017. They talk about actual mistakes in EM that people make in their practice and how it affects our minds and ourselves.
Boy, I am taking on a new role with the Academy of Physician Associates in Legal Medicine. And I just had this tremendous, again, it's a really gift from the universe about somebody on social media who shared anonymously that they were being sued by a patient. And it seemed like kind of a frivolous lawsuit from what the person was sharing. But they were so candid at how destabilizing it was for their lives. And it was really interesting about how people started coming out of the woodwork on the social media post and saying, yeah, I went through something like that too. And I spent a year and a half and I've never been the same ever since then. And it's like, wow, like these, whether it's mistakes or lawsuits, because not the same thing, you can get sued for doing the right thing. Okay. Dealing with these things can be truly overwhelming to where you can't function appropriately. You may even decide to leave your job, leave medicine, and that's kind of an extreme way about how it can affect your ability to care for future patients. But regardless, even if you stay in the job, whether you made a mistake with somebody or you got named in a suit, that can be really affecting how you take care of patients in the future. Hopefully for the better, but let's be honest, sometimes not. Sometimes we do things that are more defensive than defensible. So, first, I think it's really important, and I tell this to my students here, eventually you are going to do something to or for a patient that causes them harm. And if it wasn't for you, this person wouldn't have gone through that harm. You just have to understand that you're baking this into the cake when you get your -C as a PA or you get your, nurse practitioner degree. And you just hope that it's not a life-changing error. It's not an organ-destroying error. But we have to be willing to practice medicine with the hope that we're going to when we make decisions, we're doing it with the best of intentions and with all the knowledge we had at the time, and full understanding that, hey, weird things happen. We're all vulnerable here, that we're willing to grieve when we make a mistake, but we don't let it define us. So
Right.
how do we do that? There's a stepwise way to avoid this that Doctors Hazen and Haber mentioned. So first suggestion is acknowledge, Martha.
Yeah. Um, that's honestly, that's like the first step in every step program is to acknowledge. And we must first identify and acknowledge our mistakes. As trivial sometimes as that may seem, in certain circumstances, if they're small mistakes versus major mistakes, we sometimes lack the insight to identify when our actions have led to patient harm. And we could practice the wrong kind of medicine or nursing for a particular disease entity and not know it, or we could interact with a patient population in less than ideal way. So we may want to protect ourselves from being scrutinized by not admitting fault. So acknowledging our mistakes allows us to take the next proper step.
I'm not sure if this is the hardest step or the one you're going to go over, but the next step is to make amends. And this is where they suggest we should spend the bulk of our emotional and mental energy. If you get frozen on the acknowledge step, that's okay. So you're kind of like hemming and hawing and you're sad about it. But then what do you do about that sadness? What do you do with those emotions and feelings and energy? The next step is to do something to rectify the situation. So take that energy, take that emotion you feel into fixing whatever the wrong was. Now, you have to do this not in a selfish way, but to figure out what does the patient need, and then go down that road. Is there anything that we can maybe learn so that the next time we encounter a patient in the same situation, we don't make the same decision? Do we write a letter to somebody? Do we make a phone call? Do we call a consultant? What do we do this next time this happens? I just want to make a point here that when there's a medical error made or the perception of medical error, a lot of practices have very specific directions about how you will make amends and what you shouldn't do to make amends. And so if you're going to reach out to a patient, I think it's really important you contact your legal department, the counsel for your practice, and figure out, what am I allowed to do here? What am I not allowed to do?
Yeah. Lastly, Mike, as we sort of conclude this episode of Riggerts, is moving on. Moving on. So once you've identified that your actions led to harm and you've attempted to right the wrong, it's critical to move on. Most of us have a hard time doing that because we're perfectionists, a lot of us, and we're our harshest critics. So dwelling on the past instead of moving on puts us at risk for making more mistakes. And, I'm quoting these doctors directly. I mean, there was no better way than these two sum this up, and I'll put a link to the paper that they wrote for their column. And what they end with is that our jobs require mental clarity. It's difficult enough to run a busy emergency department without our past mistakes constantly running through our minds. So I really appreciate that piece. This isn't the first time I've mentioned this particular 2017 article by them. And really, my parting kind of thought on it all is move on in good spirits.
There
Truly.
you go. There you
Truly.
go. If you like Ted Lasso, you could be a goldfish, as they
Right.
say on that show. Well, more information on the ways you can find us here, out there in the interwebs or in real life, on the original and advanced emergency medicine boot camps, the emergency medicine and acute care course, or any of our courses are available at the Center for Medical Education website. The Center for Medical Education website. That's www.ccme.org, www.ccme.org. And I see you, Martha, hawking our Hawaii emergency medicine and acute care course coming up this year. Is that right?
Yeah, it's March 10th through the 14th. So check it out. It's for the Acute Care Series course. And also our original boot camp is in November of this year. So stay tuned and check back for more for our educational goodness.
I'm just going to put it out right now. Kelly Clarkson is doing a residency in Las Vegas this year, and a concert will be going on during the November running of our emergency medicine boot camp.
So I'm beginning to think that you have some kind of problem, because this is like the 7th time you've mentioned it. And I think you're going to regret mentioning this again.
I will have no regrets about this at all. I'm going to move on in good spirits. Thank you
What
for listening.
doesn't kill you makes you stronger.
Oh man, gosh.
You like that?
I want to hear that one. I want to hear Behind These Hazel Eyes. I've got a whole list. I've got a song list. I keep on emailing it to her. I don't really get a response back. I don't understand what's going on there. Anyways, thank you for listening and attending this episode of The Two View. You can subscribe and rate us on Apple iTunes Podcast, Spotify, YouTube Music. Search for Two View Emergency. That's the number 2 View Emergency, and it'll come right up. Ratings help us climb the charts so that other clinicians get some Two View goodness and maybe take the time to consider their regrets or how to avoid them in the future. If you like YouTube and you want to see the video blog, instead search for Center for Medical Education and you can catch the video version. Don't forget our website, where you can go next level on any of our topics from any of our episodes, including all the papers and sites we refer to. That is twoview.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett. Show notes are by Meg Dipple.
Well, I regret to inform you all that this show is now over. So thank you for again for tuning in. Friends in EM, share this podcast with a friend. Share your thoughts via email. And thanks for sharing your time with us today on The Two View. Have a good day and a great shift. What doesn't kill you makes you stronger. I'm a little longer.
Front row. I'll be in the front row for this. I can't wait.
Peace out, homie.